Thank you, madam, for such a wonderful introduction. Very good evening to my esteemed ophthalmologist, friends, teachers, and my friends. So for the next 10 minutes, I'm going to talk about the corneal comorbidities in cataract surgery. Yes, we have a lot of corneal problems which we face across every day with every patient walking into our clinic. So the most common, the relative common, and the rare common problems which will be discussed in detail. So coming to the most common problems, the corneal scars and the pterygium. So what about the pterygium? The main problems which we face across in pterygium is visualization. A pterygium greater than 3 millimeter, we might not be able to see the cataract properly. It might cause more irregular astigmatism, so which can be corrected by sequential surgeries. The scar in previous excised pterygium, which would be covering the visual axis, you can either plan for a toric IOL if the astigmatism is regular, or plan for a TCAT followed by cataract surgery after regularizing the cornea. And yes, as such, the astigmatism as well. For small pterygium, simultaneous surgeries can be planned if the patient is okay of the cosmesis and the topography shows regular astigmatism. So pterygium like this, where you can see the topography is almost regular, and if the pterygium is on the nasal side, you can actually plan for a clear corneal temporal section, which does not cause much abnormalities. And for pterygium like this, which is encroaching 3 millimeter or more into the cornea and causing a very bad irregular astigmatism in topography, always go in for a sequential surgery. So after the surgery of pterygium, we should wait for around 6 to 8 weeks for the corneal stability, repeat the topography as you will find a change in the K value, and then plan the type of cataract lenses accordingly. A temporal approach is well preferred, and surgeries like small incision or extracapsular cataract extraction is best avoided in these conditions, as post-pterygium surgery, you must have taken the graft harvested from the superior conjunctiva. And coming to the corneal scars, so the visualization, the IOL power calculation, astigmatism, and the combined surgeries are different type which we can deal with cataract surgery. So here is a small video which I had taken to show that there is a leukomatous scar in the central, but it is little off visual axis. So actually, if you avoid the scar, and you can try to continue the cataract surgery if it does not cause any very severe irregular astigmatism. Topo K is required, and definitely third generation IOL formula calculation is a must for these cases. As you can see that the trenching is all done off visual axis. And a small pupil dilatation with the vitrectomy is done so that the visual axis is a bit clearer. So the efficacy of the Chandelier illumination in combined cataract surgeries and penetrating keratoplasty is also one way to visualize the anterior capsule clearer. So then you have the Fargo's illumination. Normal coaxial illumination, as you can see, it gives a lot of scatter, whereas you see an illumination from the light pipe, you have a clearer depth of perception and clearer view of the cataract as well. So here is a video which I had taken where a 26 gauge sclerotomy port is made, and then initially the light pipe is in the anterior chamber where the anterior capsule is taken as a flap, and then later on, once the surgery, the flap is initiated, it is fixed in the sclerotomy port, so that, look, this is what we get once it is inside the eye. So even in a case of a diffuse scar, which the anterior chamber details are hazy, you get a clear glow from the posterior chamber. In this, the microscope light is actually off, but you can actually see all the details, structures, and the stereopsis very clearly. The whole phaco surgery and the IOL implantation as well can be done with the microscope off, or later on, as you can see that you can also switch on the microscope light and have the view as well. So what about the irregular astigmatism in corneal scars? Yes, topography is definite must, which has given a more clear information rather than keratometry. Use of more than one third generation formula to choose the highest IOL power calculation is must. And if the scars are superficial, there are surgeries like the PTK for central superficial opacities, and then regularize the cornea either by topo-guided PRK, which will help in regularizing the corneas. In case the corneal scars are not hampering much of the visual axis, just causing an astigmatism, you can plan for a toric IOL as well. So this is a study where I have seen a sutureless anterior lamellar keratoplasty is done for a patient with a superficial scar, and instead of suture they had actually stuck it with glue, the fibrin glue. So what the relative common indications, coming over to the dry eye, the ectasia and post-retractic surgeries. So dry eyes, usually shimmers is a must for all patients before taking up for cataract surgery. If the patient is having severe dry eyes, post-operatively avoid NSAIDs. Start on lubricants pre-operatively and continue post-operative. It can either be lubricant drops or gel form, and even oral omega-3 fatty acids are required. If the fluorescent clearance time, that is the FCT, is good, so that means that the tear production is there, we could also plan for a punctal cautery on table after the cataract surgery or before you start the cataract surgery. Coming over to keratoconus, the main concerns are the preoperative issues for the IOL power calculation, the intraoperative issues, and the postoperative issues. So here is a case which I want to show, a 21-year-old girl who has an unilateral advanced keratoconus due to VKC, has a steroid-induced cataract. So with a keratoconus whose PACI was less than 365, collagen cross-linkage was not an option. So they went ahead and did a deep anterior lamellar keratoplasty. Once after around 2-3 months, it settled, and then selective suture removal was done with topography assisted. And then once the stabilization happened, that is after 2-3 months, we planned for a toric IOL for the cataract. So the best visual acuity from counting fingers had actually improved by the end of the cataract surgery to 6/9. And this is a 60-year-old lady who had come with a defective vision for the past 10 months, who was diagnosed as from-plastic keratoconus, who had a regular astigmatism of -4 with good BCVA. So just a toric IOL will be a good choice for her to get back her vision to 6/6. So just a rough indication of what to do for a stable keratoconus. That is must. The first important thing for keratoconus is stabilize it and then plan for the cataract surgery. So what about the post-refractive surgeries? A post-myopic LASIK patient, usually the prolate cornea, it gets more oblate and it has a greater positive SA. The negative aspheric implants are better for these kinds of cases. In post-hypermetropic LASIK, which becomes more prolate, spherical lenses of all kinds can be inserted. Multifocal is not the best choice of lens implantation post-refractive surgeries because of the small optic zone following the laser treatments, which decreases the effectiveness of the multifocal IOLs. So what are the expectations? It will be very high because post-LASIK, the next day the patient regains back 6/6. So that is the exact thing what they expect after the post-cataract surgery. So chances of corneal power overestimation, IOL power calculation underestimation, and there are multiple formulas as of now which we have for post-refractive surgeries. So these are some online calculator which are there for post-refractive surgeries, either the LASIK, the hyperopic LASIK, or the RK. So the basic requirements will be the K1 and the K2, the axial length, and the A constant of each IOL for either RK or PK. The formula which we use in our hospital is the Barrett's-True-K formula. Coming over to the commonest diagnosis which is missed most of the time, the fused endothelial dystrophy. Because half the time what our mind sees, the cataract and then the surgery. And then later on we have bulle, we have epithelial edema, and then we decide that the patient must have been fuchs where we could have taken preoperative measures. So what to do first? Whether it is going to be a phaco or whether it is going to be an EK, that is endothelial keratoplasty, or a combined surgery. For phaco, if you want to do it first, instead of going only with the pachymetry, which is either about 600 or 640, also look for the visualization of all the clinical findings, whether the patient is having epithelial edema or no. If the patient is not having any edema with a corneal thickness of around 600 microns, you could actually plan for a cataract surgery alone, taking into the precautions of protecting the endothelium with proper OVDs, and then using low power, and always make sure that the anterior chamber is maintained. So as we know that the number of endothelial cells decreases with time, and decreases with time after the phaco surgery alone. But put a word to the patient that they might have to undergo a corneal transplant if required. So what about the EK first? If there is an insignificant cataract, an improper visualization of the anterior chamber, and for younger patients who need their accommodation, we could plan for an endothelial keratoplasty. But have to take into account the graft-related issues such as dislodgement, graft failure, trauma for the phaco surgery later on. And coming to the combined surgery, with thickness of greater than 640 millimeter with epithelial edema which causes scattering and defective visual acuity, you can plan for a phaco with IOL and a DSEC or a DCK. So the clinical appearance, the pachymetry, the visual needs and the counseling are very important. So this is a study which shows that the new triple procedure, that is the DSEK, is actually effective in patients who are having significant nuclear sclerosis with Fuchs dystrophy. Other stromal dystrophies such as granular and lattice, also we could either plan for a dialc alone or later on followed by phaco, or a phaco if the nucleus is severe grading, or plan for a combined surgery as I have mentioned about the endothelial keratoplasty. So this is a small video which I would show about the combined surgery. So this is a case where the trophine is done for the corneal graft, and then the nucleus you have an open sky method. With the chandelier illumination, if the corneal scar is not as significant, as I told you, the chandelier illumination can be used for a closed eye phacoemulsification and then decide on endothelial keratoplasties using the chandelier. So after the proper rexis, the nucleus is prolapsed and the rigid PMMA lens is inserted, and then the graft is placed with interrupted 10-0-16 sutures. Thank you.